Hello, Dr. Wadichka and Bio 308 class. My name is Inslayer and I'm presenting with Jalak, Tanner, and Kayla. The cancer that we chose to study was sunitinib malate, which structure is shown below here. Just like in class, here are the outcomes for the first section of the presentation. To begin, before exploring sunitinib malate as our treatment option, I will discuss some background information of the type of cancer we studied, which is renal cell carcinoma. Renal cell carcinoma, or RCC, is a kidney cancer that primarily originates in the epithelium or lining of the proximal convoluted tubules, which are very small tubes in the kidney that primarily transport urine. The kidney is traditionally regarded as an exocrine gland that produces urine to regulate body fluid volumes and composition and to excrete nitrogenous waste. In addition to these functions, it also plays a role in production of a number of hormones that have local and systemic actions. I attached a visual on the slide to show the region of the kidney that we are focusing on. If we look at the kidney and then zoom into the nephron and then zoom in further, we can see all the tiny ducts that make up the nephron, which is where this type of cancer arises. Renal cell carcinoma is not a single entity, but rather a collection of different types of tumors, each derived from the various inner ducts of the nephron. RCC is the most common type of kidney cancer in adult, which is responsible for 90% of cancer cases of this type of kidney cancer. It is most common in males and is also most prevalent in 60 to 70-year-old populations. People with cystic disease of the kidney requiring dialysis are 30 times more likely than the population to develop RCC, but overall the greatest risk factors are lifestyle-based, which we will talk more about later in the presentation. As such, RCC is often largely asymptomatic and is generally detected instantly when a person is being examined for other ailments. This means that patients often have advanced metastatic disease by the time it is discovered. As the disease progresses, symptoms become more obvious, with some of the symptoms including blood in the urine occurring in 40% of affected persons at the time that they first seek medical attention. Back pain, because the kidneys lie posteriorly, also occur in 40% of affected persons at the time they first seek medical attention. A mass in the abdomen or flank occurs in 25%, weight loss in 33%, and fever in 20% when they first seek medical attention. When RCC metastasizes, it most commonly spreads to the lymph nodes, lungs, liver, adrenal glands, brain, and/or bones. At diagnosis, 30% of renal cell carcinomas have already spread to ipsilateral renal vein, and 5 to 10% have already spread to the inferior vena cava. RCC in the later stages is also associated with PNS, which are conditions caused by either the hormones produced by the tumor or by the body's attack on the tumor. PNS is present in about 20% of the diagnosed patients, usually results in high blood calcium levels, high blood cell and platelet counts, or in rare cases, difficulty in walking, swallowing, loss of muscle tone, loss of fine motor coordination, slurred speech, memory loss, vision problems, sleep disturbances, and dizziness. The recommended treatment for non-metastatic or localized renal cell cancer is a nephrectomy or partial nephrectomy. And if cancer is only in the kidneys, as is in the case of about 60% of the patients, it has up to a 90% 5-year survival rate with surgery. But if the metastatic disease is present, surgical treatment may still be a viable option. It just depends on what stage of growth and how far the disease has spread.
Okay, so here are the biological subtypes, the most common ones. We have clear cell renal cell carcinoma, papillary renal cell carcinoma, and chromophobe renal cell carcinoma. A little bit about each one. Clear cell is the most common. It does have, with early diagnosis and 5-year survival, 50 to 69%. While if the cancer spread, the 5-year survival is lowered to 10%. It spreads aggressively. Papillary renal cell also spreads aggressively. The prognosis on that one is a little bit tougher to determine because it's so rare. Not many people have actually had it, so the statistics are typically inaccurate. And chromophobe renal cell carcinoma has a fairly low mortality and only makes up about 5% of all RCC cases. Clinically speaking, the subtypes we are focusing on with sunitinib is advanced RCC and those who have had a nephrectomy previously. The treatment of advanced renal cell carcinoma has posed a challenge for decades, in part because of common themes related to intrinsic resistance to cytotoxic chemotherapy. As such, forward movement in the treatment of renal cell carcinomas can be approached in two ways: biological subtypes by splitting the tumor types along histologic and molecular features in the hopes of coupling highly precision-focused therapy on a subset of patients who have disease with the most potential for benefit, or by clinical subtypes, where we are lumping the various biologies and histologies together to include the rare renal cell carcinoma types with the more common subtypes. The former strategy satisfies the desire for customized precision in treatment delivery, whereas the latter strategy allows clinicians to offer a more therapeutic options for a set of diseases we are continuing to learn about on a physiologic and molecular level. So RCC is commonly caused by or associated with mutations in the short arm of chromosome 3, with the implicated genes being either tumor suppressor genes like VHL and TSC or oncogenes like c-Met. This image on the top shows short arm of chromosome 3, and we can see that deletion, mutation, or methylation of the top part, labeled 25, inhibits the tumor suppressor gene. VHL from functioning properly, the VHL protein likely plays a role in other cellular functions, including the regulation of other genes and control of cell division. Based on this function, the VHL protein is classified as a tumor suppressor, which means it prevents cells from growing and dividing too rapidly or in an uncontrolled way. The loss of VHL protein activity in this case results in an increased amount of HIF1A and thus increased levels of angiogenic factors, including VEGF and PDGF. In class, we discussed VEGF as being catnip for cancer, and that is what we see here as well. Because VEGF, or vascular endothelial growth factor, is a signal protein produced by cells that stimulates the formation of blood vessels, additionally, VHL has been implicated in maintaining the differentiated phenotype in renal cells. For the purpose of this presentation, we're going to focus on VHL, but as we can see, there are many ways that it can arise. The structure of the VHL protein is shown below, and I think it's interesting to see the shapes of molecules that we study and discuss. Okay, so because VHL is instrumental in the successful growth of cancer, pharmaceutical companies began to explore methods to target this pathway. One such drug invented was sunitinib. Before we discuss the mechanisms of action, we want to provide a little background. Sunitinib malate, or just sunitinib, also marketed by the trade name Situent by Pfizer, was approved in January 2006 to be taken orally as a multi-targeted receptor tyrosine kinase inhibitor. It is indicated for the treatment of gastrointestinal stromal tumor after disease progression, the treatment of advanced renal cell carcinoma, which is what we're looking at, the adjuvant treatment of adult patients who have had an nephrectomy and are at high risk for recurrence, and well-differentiated pancreatic neuroendocrine tumors. RCC is generally resistant to chemotherapy or radiation. Prior to RTKs, metastatic disease could only be treated with the cytokines interferon alpha or interleukin-2. However, these agents demonstrated low rates of efficacy at 5 to 20%, which we'll get more into.
So here are two separate depictions of the mechanism of action of sunitinib in addition to other drugs that work in similar ways. Arrows indicate on both images where sunitinib is. In order to best explain the role of sunitinib, we're first going to return to the mutated VHL, shown at the bottom of the image on the left and the top of the image on the right. The main action of the VHL protein is thought to be its E3 ubiquitin ligase activity that results in specific target proteins being marked for degradation. The most researched of these targets is hypoxia-inducible factor 1A, or HIF1A, which is a transcription factor that induces the expression of a number of angiogenic-related factors. HIFs are necessary for tumor growth because most cancers demand high metabolic activity and are only supplied by structurally or functionally inadequate vasculature. Activation of HIFs allows for enhanced angiogenesis, which in turn allows for increased glucose uptake. While HIFs are most active in hypoxic conditions, VHL defective renal carcinoma cells show constitutive activation of HIF even in oxygen-rich conditions. So when tumor suppressor genes VHL is mutated, it continually activates HIF, which as a transcription factor induces the expression of the EGF and PDGF, which bind to their specific receptors and lead to increased and uncontrolled angiogenesis. But with sunitinib, both VEGF and PDFR are inhibited by targeting multiple receptor tyrosine kinases, or RTKs. If the kinases can't phosphorylate and activate the angiogenic factors, then angiogenesis cannot occur.
So sunitinib malate as a targeted therapy, it is a cytostatic multi-targeted tyrosine kinase inhibitor. It inhibits several receptors, including VEGFR, PDGFR, stem cell factor receptors, FMS tyrosine kinase, and macrophage colony stimulating factor receptors. It generally just decreases endothelial cell proliferation and vascularization by blocking the RAS, RAF, MEK, ERK cascade. And previously, TKIs had limited efficacy and poor pharmacological properties. Sunitinib has high bioavailability and nanomolar range potency against RTKs, which is the reason behind making it. So when using sunitinib malate for RCC, the dosage that the FDA approved was 50 milligrams orally once a day using a cycle treatment of 4 weeks on treatment, 2 weeks off for 9 6-week cycles. Sunitinib is used as the first line of therapy for patients with advanced RCC and is also used as an adjuvant for patients who have had a nephrectomy and who are at high risk for recurrence. Resistance is a big issue with this drug. 30% of patients are resistant from the start intrinsically, and a study found that those remaining 70% will eventually become resistant within 6 to 15 months. Although it has not been exactly determined what causes the resistance, it is believed to be two main things. The first thing being restoration of angiogenesis through the activation of VEGF-independent pathways, and the second thing being decreased bioavailability through efflux or lysosomal sequestration.
So sunitinib has a very narrow therapeutic index because there's a very small range between the therapeutic and toxicological effects. MTD means maximum tolerated dose, and in this case, it's 50 milligrams per day per cycle of therapy, as discussed in the previous slide. And also, as discussed in class, the side effects are placed into categories or phases based on severity, with categories in grades 3 and 4 being the most severe and unbearable, usually requiring hospitalization, and grades 1 and 2 being bearable, definitely not pleasant, but not as severe. The most common side effects that occur in 30% of the patients are fatigue, diarrhea, nausea, vomiting, heartburn, taste changes. But the main problem is the very narrow therapeutic index. As we said before, the maximum tolerated dose is 50 milligrams, but that's also the recommended clinical dose. So the maximum tolerated dose and the clinical dose are basically the same thing, which shows just how narrow the therapeutic index is.
In this section of the presentation, we will discuss the epidemiological aspect of RCC by describing the public health problem that RCC presents, discussing the epidemiology of a known or suspected risk factor for the disease, which in this case is done by using a case control study on hypertension, and discussing the efficacy and side effect profile of our chosen intervention. Looking at a chart on the right, the percentage of people diagnosed with each stage of this disease is shown. Combining the two sets of data on this slide, we learn that the 5-year survival rate for patients diagnosed with stage 1 and 2 RCC is very hopeful, but only makes up roughly 55% of patients diagnosed. 45% of the patients that are diagnosed are in stages 3 or 4, and almost 20% of which are in stage 4, which only has a 10% 5-year survival rate.
Incidence and mortality statistics. A total of 96,058 RCC cases were identified, with 54,000 RCC deaths between 1973 and 2014. Overall incidence rate was 9.712 per 100,000 persons year, and it increased by 2.79% per year. Rates have become stable since 2007, with only increase in the incidence of clear cell subtype. The overall RCC mortality rates have also been declining since 2000, despite the incident rates increasing.
Smoking increases the risk of developing renal cell carcinoma. The increased risk seems to be related to how much you smoke. The risk drops if you stop smoking, but it takes many years to get to the risk level of someone who has never smoked. People who are very overweight may have a higher risk of developing RCC, and obesity may cause changes in certain hormones that can lead to RCC. The risk of kidney cancer is higher in people with high blood pressure. The risk does not seem to be lowered even if someone is taking medicines to treat their high blood pressure. We will discuss this risk factor further on future slides. People with a strong family history of renal cell carcinoma have a high chance of developing this cancer. This risk is highest for people who have a brother or sister with the cancer. Workplace exposures include certain substances such as trichloroethylene, which increases the risk for RCC. RCC is about twice as common in men than it is in women, and African Americans have a slightly higher rate of RCC than do whites, and Black men are most likely to get kidney and renal pelvis cancers, followed by white men. African Americans generally present at an earlier disease stage, however, survival rates are worse. Studies suggest that the distribution of RCC histological subtypes is not equivalent in different racial groups. Clear cell RCC is most common in Caucasian populations, and papillary RCC is most common in people of African or Afro-Caribbean descent. Certain medicines like acetaminophen may be linked to an increased risk of RCC, and people with advanced kidney disease, especially those needing dialysis, have a higher risk of RCC. And genetic and hereditary risk factors like the von Hippel-Lindau disease also contribute to an increased risk in RCC.
A common risk factor of RCC is hypertension or high blood pressure. And this is a case control study that investigates whether high blood pressure and race are associated with increased RCC incidence. And hypertension was found to double the risk of RCC.
In phase 3 study, median progression-free survival was significantly longer in sunitinib group than in IFN alpha group. In secondary endpoints, 28% had significant tumor shrinkage with sunitinib compared to 5% with IFN alpha. Sunitinib treatment trended towards a slightly longer overall survival, although this was not statistically significant. Median overall survivability was 26 months with sunitinib versus 22 months with IFN alpha, regardless of stratification. The first analysis includes 25 patients initially randomized to IFN alpha who crossed over to sunitinib therapy, which may have confounded the results. In an exploratory analysis that excluded these patients, the difference becomes more robust. Hypertension was found to be a biomarker of efficacy in patients with metastatic renal cell carcinoma treated with sunitinib. Patients with metastatic renal cell carcinoma and sunitinib-induced hypertension had better outcomes than those without treatment-induced hypertension. During randomized phase 3 trials, 750 untreated metastatic RCC patients were given sunitinib or IFN alpha to study the progression-free survival and overall survival. The incremental cost-effectiveness ratio of sunitinib was a lot higher compared to IFN alpha, but in terms of PFS, sunitinib had an advantage in all 3 prognostic groups. The average PFS in group of patients treated with sunitinib was significantly longer than patients treated with IFN alpha. Comparing the OS between sunitinib and IFN alpha, patients treated with sunitinib had a much higher OS, but this difference did not reach a statistical significance. In terms of side effects of the treatment, tolerability of patients treated with sunitinib had a lot more incidences of diarrhea, vomiting, hypertension, hand-foot syndrome, and neutropenia, a safety profile consistent with earlier observations during phase studies. So overall, a better quality of life was observed in patients treated with sunitinib. The most influential variables for the results were efficacy and unit cost of sunitinib, and according to the data obtained, sunitinib is considered cost-effective in developed countries.
And here are our references.